Thank you everyone for joining us this evening. We will be recording this lecture and sending it out to all registrants in the next day or two after this evening. This evening's virtual community lecture will be given by Dr. Daniel Seigerman, who is an orthopedic surgeon here at Rothman, specializing in the hand, wrist, and elbow. Dr. Seigerman is currently seeing patients at our Harrison, Tarrytown, and Manhattan offices. And the topic that he will be speaking on today is I broke my wrist, will I be okay? If you have any questions throughout the course of the lecture, there's a Q&A section at the bottom of your screen. Feel free to type out any questions you have, and we will go through them at the end of Dr. Seigerman's presentation. And I'll turn it over to you.
All right, thanks, Jen. So I'm going to take over here. Can you see this appropriately?
Perfect.
Great. So I'm going to begin. Welcome, everybody, and thank you so much for joining us this evening. I figured, when they asked me what kind of topic we would choose for tonight, I figured we'd talk about wrist fractures. We're going from the cold, ice, slippery surfaces to the summertime, hopefully soon. So we'll be more outside, and unfortunately, in both those sort of circumstances, we see broken wrists. So I broke my wrist, will I be okay? So I guess the most important thing to talk about is what is a wrist fracture, right? A wrist fracture is a broken bone that occurs anywhere within the wrist. The wrist is made up of two forearm bones called the radius and the ulna. And then there are a number of carpal bones within the wrist where those two forearm bones meet. And for the majority of this talk, we're going to talk about the most common type of wrist fracture, which is called a distal radius fracture. And that's this bone right here. So how does it happen? This is typically what we call a foosh injury, or a fall onto an outstretched hand. It can be sort of dramatic, like this picture off to the left, where someone falls off a horse or from a height, but it can be, from a standing height, from a couple of steps. It happens all the time. And, with respect to how these types of falls happen, it's important to think about some special considerations. There are two types of injuries that we see when people break their wrists. So one is a low energy mechanism, and that's usually a fall from a height. So if you're standing upright and you fall down. Things like wet floors, inappropriate footwear, area rugs, such as is seen in this picture, can be the culprit for these types of falls. And then there are high energy falls, and those are ones that are caused by high energy injuries, such as car or motorcycle accidents, sports injuries, and people who fall from a high height, such as someone fixing their gutter. So when we ask people about wrist fractures, one of the more important things to know is when you need to go and get it checked out. And so there are some red flag signs that are absolutes, that when you see this, you need to go get it checked by a professional. These include some wrist deformities. So if you see here in this picture, this individual has this standard, what we call dinner fork deformity of their wrist. Significant swelling after an injury, obviously loss of sensation if you have numbness in your fingers. If there's a skin break or bleeding or persistent bleeding from an area around an injured part of your wrist, these are things that really indicate you going to get it checked out fairly urgently, either same day, and usually same day or immediately. Other circumstances, if you fall, you have a wrist and it doesn't get better, or it's getting worse, and you don't have any of these red flags, you can always have it checked. But certainly these sort of red flag signs are more of an urgency. People always ask me, where should I go? And the available places to go are, an ER, urgent care facilities, and, places like our office. In the pandemic, what we've noticed is there's a lot less people going to the emergency department, trying to stay away from other people. The emergency departments, especially, a year ago, were inundated with COVID and respiratory illness, and people were staying out of there. So we used our office to see these patients a little bit more urgently in more of a controlled setting. Urgent cares are excellent for this as well. So one thing people might ask is, okay, I have a deformity or I'm bleeding from my wrist after a bad fall. I think I might have a fracture. What's going to happen when I go to that ER, urgent care, or to our office? So the first thing we need to do is make a diagnosis. And luckily, when it comes to broken bones, they're pretty easily identifiable on X-ray in most circumstances. So we're going to take an X-ray. Actually, it's 3 X-rays of the wrist in various views. And that helps us to make the diagnosis to confirm whether you have or don't have a specific fracture. At that point, if a fracture is identified, then we usually begin with an initial treatment. And in this case, it's called a closed reduction, which is where the wrists are basically set back in place. So if you have a displaced wrist fracture, meaning that the fracture occurred and the bones are not lined up appropriately, there's a procedure that we can do emergently or urgently to reduce the wrist fracture back to its more comfortable position. And based on that initial displacement, so if it's a displaced wrist fracture and it's set back in place, or if you have a fracture and it's not very displaced, oftentimes that can definitively be treated with a cast or a splint. But if it's an unstable fracture, or if it's a fracture that's still unstable or not reduced appropriately after the closed reduction procedure, that's when surgery is often indicated. This is a sort of a picture found on the internet of a gentleman who's having a procedure called a closed reduction. Oftentimes what we do is we hang the limb up in the air with these finger traps, and that allows gravity to pull down on the arm and stretch out the fracture so that it's better aligned. And this is a common technique that we use in the emergency department, in our office, or in urgent cares, throughout the country. So let's take a step back and talk about who gets wrist fractures. So this is Aaron Judge on the Yankees. He had a wrist fracture. Obviously, that's a high energy injury when I believe he got struck by a baseball coming in probably 90 plus miles an hour. And this is probably someone's grandmother who fell and could have a wrist fracture. These are sort of the 2 different demographics that I see with wrist fractures, specifically distal radius fractures. And when it comes to wrist fractures, age is increasingly important. So our literature has sort of divided this, and those folks who are older than 65 years old typically have more low energy injuries, sometimes simple fracture patterns, but not always. And they're more likely to be amenable to non-operative management because sometimes they break their wrist, but it's not terribly displaced. Sometimes they are displaced and they do need surgery. But those patients who are a little bit older, they may tolerate greater deformity than our younger patients. So we know that even if a wrist is not in perfect alignment, if you're a little bit older, our literature shows that those patients do quite well and can accept a little bit of a deformity and live a perfectly productive, normal, pain-free life. But there obviously are exceptions. Here's a picture of one of my patients who sustained a pretty mild wrist fracture. You can see here, there's a fracture right here in the bone called the distal radius. And on the lateral projection, it's mildly displaced. This, I tell patients, looks like a golf tee. And you want this golf tee to be either in a neutral position or actually facing forward, or in this trajectory where I'm moving my mouse pad here. This individual is about neutral, or maybe just a drop off. And this patient was placed into a cast and healed really, really well and had no limitations whatsoever. So going back to some of the age components of wrist fractures, our younger patients are often those who sustain high energy injuries. Those are people up on the roofs, falling from a real high distance, motor vehicle accidents, high-level sports injuries, industrial injuries, those at work, or labor injuries. And oftentimes, these are more complex fracture patterns. And in this younger age population, there's a lower tolerance for malpositioning of the wrist fracture. So we know, based on good, multi-center studies, most of them occurred in Europe and other countries actually, that those patients who are older do better if the wrist is left not perfect, and those who are younger don't do as well if we leave the wrist in an imperfect position. This is one of my patients who sustained a pretty high energy injury. From afar, you can probably see that on the lateral projection here, you can see that this is the wrist here. This is the articular surface or the joint surface of the wrist. And this here is the radial bone. And so this belongs up here. So the whole hand basically has fallen off of the forearm bone. And this is a pretty high energy injury, I would tell you. So how do we treat these? So we talked a little bit earlier about doing a reduction maneuver, a closed reduction, that's setting the wrist. And most displaced wrist fractures will undergo a closed reduction maneuver if they're seen in an urgent setting, such as an emergency room or an operating room. And basically what we do is we anesthetize the skin with some lidocaine, some numbing medicine. If you're in a hospital, sometimes we'll give you a little bit of sedation to take the edge off a bit. And we basically use the ligaments in your wrist to pull on the hand and realign the fracture as you've seen here. And this is a nice, effective technique that we use. When we evaluate you or the patient in an emergent setting, the first thing that I do is I evaluate the skin. So I want to make sure that the skin is intact, that there's no bleeding going on, and that's exceedingly important. The second thing I want to do is I want to examine the patient's nerves and make sure that they're feeling all of their fingers and able to move all the muscles associated with nerves around the wrist. One significant complication that can happen from a displaced wrist fracture, a displaced distal radius fracture, is some of the fracture components can be pushing on the carpal tunnel nerve or the median nerve. And that's a big problem. And those patients may develop some advancing or progressive numbness in the thumb, index, and middle finger. And that's an indication that the reduction needs to be done immediately. And if the acute carpal tunnel doesn't resolve immediately, the pressure needs to be released from that carpal tunnel and relieve pressure on the median nerve. And so in those circumstances, we often secure the fracture with orthopedic hardware and relieve the pressure on the nerve with a carpal tunnel release. We look at the deformity. You know, how bad is this thing? Is it potentially going to puncture through the skin? And then after we do our closed reduction maneuver, we always look at x-rays to see how we did, to see how, you know, what's left and what the x-rays look like after we've set the bones. This is a little bit of a gory picture of one of my unfortunate patients who sustained a wrist fracture where the bone popped through the skin here. And you can see that this patient's skin was unfortunately bleeding pretty considerably here. There's a ring on here, so this ring's gotta come off. So the first thing I say when I see a fracture and I see a ring on the x-ray, and the ER calls me as I say, please, please, please take that ring off. What can happen here is that ring can act like a tourniquet. And so after a fracture like this, you get significant swelling into the fingers, and that ring can cause loss of blood flow to that finger. So the first thing we do is take rings off, we take jewelry off, and then we image the limb. And obviously look at this injury where there's an open wound over a fracture. And this needs an urgent treatment. You could see this patient actually has some dirt here on the wrist. And so you can imagine if this bone has poked out here and there's gross debris, that is an increased chance for infection. So it's paramount to give some early antibiotics immediately in the emergency room, and then take that patient as soon as possible to the operating room so that this can be cleaned out appropriately and the fracture can be secured. And we'll look at the outcome of this patient a little bit later. We'll go back and talk about some treatment options. So in those patients where the fracture is not too badly displaced, or if we reduce the fracture and it's well aligned, it's a good idea to treat that patient in a splint and cast, and they can avoid having an operation. My personal non-operative treatment protocol is as follows, and this will differ a little bit surgeon to surgeon, doctor to doctor, and facility to facility. But in my hands, what I do typically is I monitor patients who have had a closed reduction and their bones have been set for about 2 to 3 weeks with weekly x-rays. It's very important to ensure that their initial fracture reduction doesn't lose alignment And if it does, it would need to be either re-reduced or repaired with surgery. Patients usually wear an above elbow splint for about 2 weeks. And then what I do is I convert them to a short arm cast or a splint for an additional 3 weeks. I then begin gentle range of motion exercises at about the 5-week point when that short arm cast or device comes off. I begin light strengthening at about 8 weeks. And I begin some resistance exercises and in an effort to resume full activities by about 10 to 12 weeks. So that's a 2.5 to 3 month process all in. But what happens when your fracture is displaced and it can't be held with a cast? That's when we talk about surgery. Surgery for a wrist fracture, specifically a distal radius fracture, is a routine operation to repair the broken bone. We improve alignment and we stabilize it with orthopedic hardware. And 95% of the time, I use a plate and screw construct like we see here. This is a small plate, basically just a couple of centimeters, about 2 or 3 inches in length, that sits on the palmar side of your wrist bone and secures any fracture that may live within this area here. There are a lot of options when it comes to how to do surgery on a wrist fracture. So plates and screws, like we saw earlier in that prior picture, is sort of the mainstay of treatment. But individual pins and external devices and internal plates that span the hand to the forearm are all viable options that I employ. Here are some pictures of some different options. So here's a patient of mine that had a pretty significant wrist fracture, but this patient was elderly and needed to ambulate with a walker because of some lower extremity injuries and problems. So what we did is we put this plate that doesn't even go anywhere near where the fracture was, but it goes into the hand, one of the hand bones called metacarpal, and into the forearm portion of the radius, and allows this all to heal while holding it out to length. And this patient can actually put full weight on this wrist immediately, day one. There are other sort of fancy devices like rods that go into the wrist. There are external fixators that span the wrist. This has sort of fallen out of favor with some of the new advances in technology, but still available for us to use, especially in significant traumatic, high energy traumatic settings. This is an example of that plate and screw construct that we looked at earlier, and this is sort of my mainstay of treatment. And then there's individual pins. So sometimes it's a less invasive option with the drawback of having exposed pins until it heals up. So, one of the most important, or if not the most important part of your endeavor with your wrist fracture will be your rehab. And luckily in our area, we are super blessed to have tons of really highly trained individuals who are hand therapists. Typically, they are occupational therapists, but they can be physical therapists as well. And they do extra training to become certified in hand therapy. And they are sort of the cornerstone to the rehab after the initial injuries are treated and stabilized. Here's a picture of Las Vegas, which seems out of place, but it's not. Because I was once teaching a course in Las Vegas, and I asked 3 really well-known, nationally recognized hand surgeons what their post-operative protocol was after treating wrist fractures with surgery. And here's what they said. The first individual told me that he uses no splint after surgery, begins immediately, has them move right away. He does provide them with a splint for just light activities at 2 weeks. He weans out of any splinting at 6 weeks and allows full activity as tolerated. So this is sort of a liberal surgeon who allows patients to sort of dictate their own motion and activity pretty soon after surgery. The next individual, who I believe was from the Mayo Clinic, said to me that he casts all of his wrists for 6 weeks after the operation. And another highly recognized individual told me that he puts patients, sort of does something in the middle. He puts patients in a cast for 3 weeks and then a removable splint until 6 to 8 weeks. So if you can see here, I could tell you that these 3 individuals who said this, who will remain nameless, are really well-respected hand and wrist surgeons, internationally known. And they're totally different. So there's a lot of variety here when it comes to what the rehab protocol should be. In my opinion, one of the most important things to remember is moving the fingers. So finger motion is paramount when you have a wrist fracture. Fingers like to become stiff after the swelling sets in. And if you don't lose the motion in the fingers, you don't have to get it back. So when someone breaks their wrist, on that very first day when I meet them, I tell them, move your fingers. And moving your fingers is not just going like this, it's making a full composite fist. And that, in my opinion, is one of the most important things you can do for patients who break their wrist on the night of injuries, to remind them that moving their fingers is quite important. Each therapy program should be tailored to the individual patient, the fracture, the injury, and the type of fixation that was utilized. So in my opinion, conversation between the patient, the physician, and the therapist is really the most important strategy to get someone healed up in an expeditious and effective manner. After surgery, this is my post-operative protocol. I use a plaster splint for about 10 days to 2 weeks that we apply in the operating room. As I mentioned earlier, the fingers are kept moving. I then convert that patient to either a custom-made or removable off-the-shelf splint that they wear 24/7 for about 2 additional weeks. They start therapy for motion of their fingers at 1 week if they're unable to make a composite fist. And I begin wrist motion at about 4 weeks with a structured therapy program. I discontinue use of the splint at about 6 weeks and begin light strengthening exercises. And at 8 to 10 weeks, we start a more intense strengthening program. I'll just run through a couple of interesting cases of patients of mine. So this is an unfortunate individual who had a pretty bad wrist fracture where the bone popped through an area of the ulnar nerve. So this individual had weakness and numbness as it relates to the ulnar nerve with an open or compound fracture of the distal radius. So you can see here, this is a pretty bad fracture. You can see it's in a whole number of little teeny pieces here, and it's very displaced. So you can see this sharp jagged edge here is poking this way. There's a sharp jagged edge poking this way, and the patient's ulnar bone, the secondary bone in the forearm, his pouch is sort of out here where a big laceration was. So this is a pretty big injury. So this patient actually got an external fixator and got some preliminary fixation and treatment of their nerve. So I looked at the nerve and released it to ensure that it was free of any scar tissue or any compression. And then about a week or so later, the patient was taken back to the operating room where the fracture was well repaired with plates and screws, and this pin was left in temporarily. The lady we saw earlier with that open distal radius fracture, clearly you can see this fracture is about over 100% displaced. And this jagged edge here is very close to the skin. There's a whole number of tendons and a nerve that runs in this area. Luckily, she did not injure her nerve, but it was poking through where the tendons are. The ring came off. We took her to the operating room to clean this out, and it was repaired fairly nicely with plate and screw construct. And she did well and ended up healing up that open wound pretty nicely. And that's it. So thank you so much for attending. And any questions, happy to entertain. These are my boys, by the way.
Dr. Seigerman, we have one question for you right now. The question is what is your definition of light strengthening versus resistance exercises?
So that's a great question. Usually I let the therapist sort of start some gentle strengthening, meaning a half a pound or a pound weight in their hand, and then have them start to do their range of motion exercises that they've achieved prior with a small weight in their hand. The resistance exercises, those are things like bands, and therapists have a number of tools that can work on resistance type maneuvers. There's a whole lot of exercises that therapists have at their armamentarium, but really band type exercises, things like that. That's what I mean by resistive exercises.
And I was actually emailed another question right before the lecture. This is a patient who had surgery at Rothman, but actually has been doing hand therapy since January in Malvern. They asked, will my wrist ever feel normal / be okay again? What is the normal timeline for recovery, and will the stiffness ever go away? Will I ever be able to do anything such as push-ups, yoga, ever again?
So I think that's a great question. And I think, when you look at some of the rehab protocols, the average that I mentioned there was about 3 months, right? But I've had a number of patients that have been a little bit shorter than that. And I've had many, many patients that have been a little bit longer than that, and some significantly longer than that. As a general rule, if you can obtain about 80% of your preoperative motion after your surgery and after your rehabilitation is complete, that's considered a pretty good result. Many people can do better than that, and some people do a little less than that. And a lot of it has to do with how bad the fracture is, a lot of circumstances about your anatomy and how you respond to injury, such as scar formation and things like that. And the ultimate rule, what I tell people is that, could take up to a year or a year and a half to really be at a steady state of where you're going to be for permanently. I think it's a tough question to answer as a general sense. I think there's a lot of individuality about that. I think an average of about 3 months is fair, but some patients take a number of extra months. So I wouldn't be discouraged. And I think that if any sort of forward progress is occurring with therapy, I think that's a very, very good sign, even if it's slow going.
Gotcha. And we have a few more questions. The next one is, what's your opinion regarding hardware removal, especially for female patients, to prevent any tendon attenuation?
Sure. That's a great question. At Rothman, some of my partners did a really nice, robust study. And what we found was the rate of hardware removal after a distal radius fracture was 5%. So about 5% of people need to have their plates removed. And the reason why we have it removed is because in some circumstances, based on the alignment of the fracture or the location of the fracture, the plate needs to sit in a position that could pose a risk to some tendons. If you're in that category, and we have a pretty good way to tell that based on x-rays, then the plate should be removed. But from all comers, it's usually about 5%. If the surgeon doesn't feel that you're in that category, those patients I recommend leaving the plate forever. And typically, if there's no issue with the hardware, it won't cause any long-term problem.
We also were asked, any recommendation on a solid radiology tutorial or online training resource for a PA student going into upper extremity ortho specialty?
That's a good question. I don't know of any courses, but I'm sure they're available through the academic centers, that there are, sort of formal X-ray, high-level MRI and CT studies. But to be honest, you learn on the fly, and my recommendation is you need to see these fractures. They're all individual, and, a good foundation of knowledge from, a course is excellent. And then that should be filled in with on-the-job training and really just seeing patients and seeing the variety of what's out there.
And we have one more, and I'm sorry if I word this wrong, but what is your criteria for considering elective removal of, just gonna say it, ORIF, ORF, once wrist is fully healed, such as 6 to 12 months later, ? What do you take into consideration if the physical therapist suspects lingering restriction prevents full return to normal activity?
Yeah, that's a good question. So if you remember during the presentation, there was a slide that showed a number of different fixation devices. Obviously, a plate that spans the wrist to the distal forearm needs to be removed because you can't bend your wrist with that in. Sometimes we use plates such as dorsal plates that sit on the top side of your wrist, and those often have to be removed, but not always. And plates that, in the most common category, those plates that sit on the palmar side of the wrist, those have to be removed in certain radiographic circumstances. So if it sits too distal or too close to the articular surface, or if there's a screw that happens to be too close to the joint, that plate should be removed. Otherwise, if the alignment looks okay and the plate is in a very safe position, it doesn't need to be removed. In some folks who are very stiff, if you're doing a procedure where you're trying to remove some scar tissue, sometimes the plate is removed in conjunction with that operation as well. So that may be what that person was asking with respect to their therapist.
And then we have one more that just popped up.
Sure.
How common is it to repair the triangular fibrocartilaginous complex along with the bony reductions?
That's a great question. So the TFCC, or the triangular fibrocartilage complex, is a structure adjacent to the ulna bone, adjacent to the distal radius. And so when many folks break their wrist, they can have injury to the TFCC or some of the ligaments on the outside portion or ulnar aspect of the wrist. What we do during surgery is once we repair the bones diligently every single time, we check the stability between the radius and the ulna. And I do so in 3 positions. I do so in the neutral position, in the supinated position, and then the pronated position. And that's done to make sure that the bones are stable, the 2 bones of the forearm are stable with one another, and that there's enough intact cartilage and ligaments between the 2 bones that hold everything in place. If there's any major instability, we actually often don't primarily repair the TFCC, but instead we pin the 2 bones together. And what that does is it allows for those soft tissue components to heal primarily on their own. I don't have to do that very often, and that often only occurs in those folks who have super high energy injuries. Those are the rollover MVAs, someone who falls off of a roof, really, really severe fractures. Those are the ones that I've had to do in the past. But in the standard fall from height or more lower energy injuries, it's pretty rare that you'll have to deal with the TFCC. With that being said, it is often common for patients to have ulnar-sided wrist pain many, many months, 6 to even 8 months after their wrist fracture. And interestingly, that tends to get better on its own long term. Once in a while, a patient will need a cortisone injection to sort of relieve some of the pain on the outside of the wrist, and that's not uncommon. And in certain circumstances, they need to have the TFCC repaired. But it's not common in my hands to repair the TFCC at the time of injury. Most of the time, these heal up on their own.
All right. I think you covered all of the questions. Well, we just wanted to, thank everyone for joining us this evening. And again, we'll be sending the lecture out to all attendees who registered.
Oh, Jen, we actually have one more.
Yep.
Is there typically any problems with ulnar variance changes following reductions in ulnar-sided wrist pain?
So that's an interesting question. The ulnar variance, the person who asked the question is referring to, is the length of the ulna as it compares to the radius. And so when people have a relatively long ulna as it compares to the radius, it can cause soft tissue injuries to the ulnar aspect, that structure we were just previously talking about, the TFCC. And it can also cause the ulna to rub into some of the carpal bones, like the lunate and the triquetrum. And that can be a problem. So what happens, the way that can happen as it pertains to a wrist fracture is if a distal radius fracture is sort of fixed in a shortened position, or it's fixed, or it's not fixed and it heals in a shortened position, that can effectively make the ulna relatively longer. And yes, that can cause some ulnar-sided wrist pain and ulnar difficulties. The remedies there can be as mild as some time and therapy, Cortisone injections can sometimes help in certain individuals, and in others, you need to do surgery to sort of correct the anatomy. And to correct the anatomy, one would either lengthen the radius or would remove or shorten the distal portion of the ulna. And that's sort of a specific situation, person to person, and age has a fairly big impact in how you treat that.
Awesome. All right.
So thanks so much for everybody for attending. Hope you enjoyed and have a wonderful evening.
Thank you, everyone. If you have any questions after tonight too, my email's on the reply email. So any questions you have, I can make sure that I direct them to Dr. Seigerman and get those answered for you.
And my email is right here as well. So anyone, feel free to email me.
Awesome. Thank you.
Have a great night.
Thank you, everyone. Have a great night.